Welcome to Emergency Medicine Review, your one-stop shop for the critique of all things emergency medicine in television and film. I'm Dr. Grumpy, MD, a real emergency medicine doctor. Please keep in mind that the things that we're talking about today are intended as critique of television and film. They are not actual bits of medical advice. If you're having something weird go on, please go see a healthcare provider. Today we're going to be tackling trauma care in the show Chicago Med.
That way.
Ugh, yikes. Okay, I'm already a little bit frustrated, and we have some things to talk about. And I know what you're saying, Dr. Grumpy, you just like to get frustrated about things. And that's pretty true, but there's something pretty egregious here that we're going to get to in just a second. But first, let's head on over to the context corner where we like to just dump exposition on our fans. So the show is Chicago Med. It follows a bunch of healthcare workers in a major metropolitan area that just happens to be Chicago. And the rest that you need to know is that these are two of the major characters, both of which are emergency medicine doctors. They've been involved in a motor vehicle collision close to the hospital, and one is caring for the other in the pre-hospital setting. And that brings me back to what's making me so damn grumpy just a couple seconds into this episode, and it has to do with how he is holding his colleague. So the concept here is you have your spine, you have the bones in your spine, but you also have a cord that goes down it that contains all the nerves that control everything in the body. Walking, sensing, breathing, literally everything. And in high mechanism trauma, there's potential that you've injured either the bones in the spine or the spinal cord itself, which can be irreversible. So the 30,000 foot view here is try not to move people's spine too much before they get to the hospital if you can avoid it. So while we can all agree this is a really cool shot with Chicago in the background and he looks like a major hero here, it's probably best if he would just lay his colleague flat, call 911, and let the first responders do their job. All right, we're gonna move forward, cut him a little slack here. I'm sure it's gonna get better.
Dr. Halstead!
Oh yeah, good job, hero. You did it, you nailed it. Dr. Doink here just carried her from the top of a parking garage all the way down to the hospital, just making sure to just shake her spine as much as possible on the way into the hospital. If you're in this situation, call 911. It's that simple.
What am I looking
Well,
at?
we're finally at the
Dr. Manning was
hospital,
thrown
so
from
we'll
the
put that in
vehicle.
the positives.
Bloodhead trauma, loss of consciousness. Hey, Elsa?
Yep.
Put a collar on her. Start an IV and get her on the monitors. And a nasal airway.
Once again, not to belabor the point here, because it wouldn't be unreasonable to put a collar on, but we've probably already jiggled her spine out of the usefulness of that. And then Dr. Doinkmeister suggested that we put in a nasal airway. That's a little device that goes in through your nose. It's a piece of rubber that gets the tongue out of the way of the airway. I'll just say that in this setting, most people would not do this, and that's likely pretty unrealistic. Okay, but we're finally getting into some trauma care here, so let's put on our learning hats, you knuckleheads. What's happening here should be the primary survey, which means we are going through and we are looking for things that could kill the patient right away, things that we need to intervene on right now, and that starts with the ABCs. So the ABCs are just fundamentals of the first part of trauma care, and they stand for airway, breathing, and circulation. And basically what they mean... Wait, hold on. What is this? What's this guy doing with a sterile towel? What are these sterile towels for? We need to stop our education for a moment and just recognize that there's no use for a sterile towel on this woman's legs in this current moment. It really feels like there's some stockpile of sterile towels that Hollywood got a hold of, and they're just like, well, we gotta use them. Okay, I digress. Back to the education. The ABCs are just the fundamentals of trauma care, and they're the first things that we're going to intervene on to save someone's life, and that may mean a ventilator and intubation for A, a chest tube for problems with the lung and B, C, maybe giving someone blood because they're losing blood. These are the things to fix first because they're the first things that are going to kill the patient. All right, we're finally getting to our primary survey here after all the drama.
Talk to me. She's not protecting her airway. She's clamping down.
The thing that really sticks out to me here is this is probably what I looked like when I first did my first resuscitations as a resident. His exam is just kind of all over the place. He's not really following a logical paradigm as he goes through it, and that just sticks out when you've done this a lot. And then the other nitpicky thing is he said, quote, she's clamping down, end quote. That is just nonsense filler talk to make it sound like he knows what he's doing. It doesn't fit this context at all, and it doesn't have anything to do with the airway. But let's go for it. Let's take the airway, do some critical care here. Yikes.
I'm in.
Oh man, speed demon here with the airway. That's good. We'll put that in the positives. But, oh boy, there's just a lot to unpack there. So problem number one is this is a trauma surgery fellow who's doing the intubation, which is not realistic. In general, surgeons do not deal with the airway, at least this type of surgeon, unless they've had very specific training, like potentially critical care training. Usually, it's going to be either an emergency medicine doctor or an anesthesiologist that's doing the intubation in this setting. Unless there's a need for a surgical airway, then the surgeon might be involved. This just speaks to the fact that we have different medical specialties. We go through different residency and training, so we can do all the different things that are needed to take care of people. And then the second thing to acknowledge here is that the positioning of everything is just kind of not great. First of all, in his right hand, he's got the breathing tube. You wouldn't do that to start. The right hand can actually help you kind of open the mouth a little bit as you do this process, and someone would hand you that tube once you have a good view of where you're going to intubate. There's also somebody holding the collar there, which is not helpful at all. In fact, we would probably open the front of the collar and have someone do stabilization of the spine while we intubated, so that's not good positioning. And then trigger warning here for our more experienced healthcare providers. In general, we probably would do video intubation as opposed to direct intubation because it tends to move the neck a little bit less. Might as well use those modern tools where you can. We will give him style points, though, for doing it direct intubation. Let's go ahead and check back in on Dr. Doink.
If Dr. Halstead had let me give him a proper examination, this never would.
It's not your fault. Will, I need to admit you and put in a chest tube.
You're at risk for attention.
This medical student wouldn't even
Right.
be talking in this situation.
Put in a one-way valve tube.
That is not protocol.
Elsa, please.
Just as a quick aside, the medical student, the one in the white coat here, would not be talking to these two supervising doctors about protocols or treatments. They probably wouldn't be talking in this situation at all. And then on top of that, the one who's getting treated probably doesn't even know the medical student's name. So they would have been like, who are you? And then what was happening was Dr. Doink was giving a wild medical suggestion so that he could go home and not stay in the hospital, which is where we were.
Will, I need to admit you and put in a chest tube.
You're at risk for attention pneumothorax. You could die.
She's right.
Aspirate and put in a one-way valve tube.
Bad idea.
That is not protocol.
Elsa, please. You'll temporize me and I want him to be admitted.
Look at this doctor's face. He's like, you son of a bitch, I'm in. This whole situation is so out in left field in regards to medical care. I'm not even going to touch it. We're just going to move on. Let's just fast forward a bunch here and see how she did.
Dr. Manning, can you hear me?
That breathing tube is so far out of her mouth, it's not even in her body at all. What are you doing? What is this?
She's breathing on her own. Dr. Manning, pull your tube.
Oh God, I don't know what that was. But it was not clinical medicine. Don't do that. Oh God. Well, it looks like she survived. We'll just stop on her face there. That is the look of like, none of that clinical care made sense. My God, my colleagues are idiots. Let's just check in on the rest of the hospital, make sure everything's going. What is happening here? Wait, why does no one have gloves on? Why does no one have masks on? You know, we should probably have masks and gloves on while we do this critical procedure to save this person's life. You know, I'm a little overwhelmed. Maybe we need to come back to this part of the show and explore it next time. Whew. Well, that is a head in your hands kind of moment right there, but I think we've wrapped up our first experience with Chicago Med here, but fear not, we're definitely going to be coming back for some second servings. I hope you learned a little bit about trauma care today, and with that, we'll catch you on the flip side.